Hello, my name's Florence. Welcome to the theobspod. I'm an NHS obstetrician, hoping to share some thoughts and experiences about my working life. Perhaps you enjoy Call the Midwife, maybe birth fascinates you, or you're simply curious about what exactly an obstetrician is. You might be pregnant and preparing for birth. Perhaps you work in maternity and want to know what makes your obstetric colleagues tick, or you want some fresh ideas and inspiration. Whichever of these is the case, and for that matter, anyone else that's interested, the theobspod is for you. Episode 18, Handover. Today I'm going to talk a bit about handover. Team handover at the beginning and end of a shift. Handover between individual members of a team, perhaps between wards, perhaps between individual members of staff, and between different teams within the hospital. Handover is a really important time. It's a risky time because information may be lost, and it's about ensuring that the team coming on have really understood what we're trying to tell them. So I'm going to start talking about team shift handover. On our labour ward, on our maternity unit, we hand over at 8 and 8. So that means we'll gather together all the members of the team. So we'll have, if we take morning handover, the night team, so the night junior doctors, of which there'll be 2 or possibly 3, depending on their grades. We'll have the oncoming junior obstetric doctors, specialty trainees, of which there will be 2 or 3. We'll have the midwife who's in charge of the day shift. We'll have the midwife bleep holder who's kind of in charge of the maternity unit. We'll probably have the off-going anaesthetic doctor and an oncoming anaesthetic doctor who may be a consultant. We'll have information from the neonatal unit, and we'll have the obstetrician, the consultant in charge of the day. So that's quite a lot of people. And you need to have some structure to make that handover sensible. We have a large whiteboard in which all the information is written. And to make it easier to immediately assess the workload and what's happening, that whiteboard is colour-coded. So that gives us a visual cue immediately. So on our whiteboard, women in blue are antenatal. So that might be a woman being admitted for a caesarean, or a woman in early labour, or a woman being induced. Red on the board is established labour. So that woman is in labour, contracting, progressing. And green is postnatal. Green is she's had her baby, but there may still be issues that we need to deal with. So when I arrive at the labour ward board, I can immediately tell roughly how many women are in labour and what the workload looks like. As well as that colour coding, we can also rag rate red, amber, green. So as we go through the board, we can decide what the priorities are, red being high priority and green being low priority. So what are we handing over? In my unit, we're handing over the labour ward. We're also handing over antenatal patients, not usually all of them, but the higher risk ones. So perhaps women that are actively bleeding or need decisions about delivery or need review or are unwell. And postnatal, again, not necessarily everybody, but women that have been readmitted with a postnatal problem, women that have had potentially a longer stay postnatally because of complications and need additional medical attention. So that's quite a lot of information we've got to impart. And some of those women will have been seen by the team during the night, but some of the women will not have been seen overnight And that can be a little bit risky, that you can get into a bit of a situation of Chinese whispers. So if the team that came on at night didn't see some of the antenatal or postnatal women, it may be that they're handing over what was handed over to them. And remember, they're doing this at the end of a 12-hour shift, and they're tired, and they will have done multiple other things at the same time. So sometimes things can get a little bit lost in translation, a bit like the game Chinese Whispers. If someone says something to you and then you say it on to somebody else and then somebody else says it on to somebody else, that information might get a bit garbled on the way. I sometimes see this when I actually know the woman they're talking about. Perhaps I have been on a shift and I'm already aware of her. I already know quite a lot about her, or possibly she's one of my patients that I've been seeing in clinic. And it can be interesting to hear second or third hand what is being said about someone. And then I can interject and say, actually, I know this woman and this is the situation and the issues. So as I mentioned, handover is a bit of a risky time. We sometimes see that in our risk reviews that I discussed in my mistakes episode. And that's because it's a bit of a dead space. It's a time where one team are tired and are going off, and one team can't necessarily start the workload before knowing the situation and what's going on. So there's a little bit of dead space, dead time, and it can be really important to ensure that what you think is happening is actually happening. Sometimes I'll turn up and they'll tell me that a woman is going to theatre at that moment, and I will take handover assuming that she's in theatre having her spinal anaesthetic or her epidural topped up, and that she's getting ready for me in that time while I'm taking handover. And then when I finish handover, I go to the theatre expecting that that woman is ready, only to discover she's not at all, because she was still actually in the room because they were waiting for us to finish handover. And that doesn't happen very often, but it does happen. So it's very important that you check what your new team is doing and what the previous team is doing. And it can be difficult because you might want to stay beyond your shift, but you can't always stay beyond your shift. It might seem kind to say and look after a woman, either as a midwife or a doctor, that you've been with all night or all day, but she might actually benefit from someone that's fresh and can see things anew, who isn't exhausted. And also, if you're coming back for another shift that evening or the next day, actually, you need that downtime. You can't stay a long time beyond your hours and then be fresh and ready to look after the next set of women the following day. So, although sometimes we hand over at a very difficult time, and that's a risk, it may be more risky not to hand over and to stay late. So there's a little bit of judgment there. Sometimes we will stay and see things through, and sometimes we won't. And I know that can be sometimes upsetting for women, that they've been looked after by one set of staff and then in come a completely fresh set of people. But sometimes that is better. 12-hour shifts are long and exhausting, but there is some benefit to them in terms of it minimising the number of handovers. If you hand over, so for example, we used to have a rota in which as consultants we handed over in the morning, at lunchtime, at 5 o'clock, and then at 8 in the evening. And we moved away from that because it was too many handovers. It was too many times of breaking up the day, too many exchanges of information. And if you have a longer shift, you have more continuity for the women and the staff, and also more investment in the outcome. You are much better prepared to see through someone's labour if you're there for 12 hours and you know that that woman is going to have her baby on your shift than if you're what we call sometimes babysitting for maybe only 3 to 4 hours, in which time actually very little may have changed. So how do we hand over? Well, we try and use a structure because that makes it easier. So there's a very well recognised structure called SBAR, and that stands for situation, background, assessment, recommendation. So a handover using SBAR might comprise of situation. This lady is in established labour and she's 5 centimetres dilated and she has an epidural. Background might be, this is her first baby and she has been induced because the baby is slightly growth restricted or small and she had a hormone pessary to get the labour started. Assessment might be, she's currently doing very well. We're happy with the baby's heartbeat trace. She's on continuous monitoring of the baby's heartbeat because of the growth restriction. All her observations are normal. Recommendation might be, she's next due an examination at 10 o'clock in the morning to decide whether or not she will need a hormone drip in addition. So that gives you a little bit of a feel for how the SBAR structure works. It's important because it gives all the right information about the woman, but it also gives our recommendation of what we are imagining if we were staying would be likely to happen next. It can be difficult when we've got multiple women with very similar stories. Say on the labour ward, we've got a large number of women that are being induced or that have had a very similar picture overnight. And it can also be difficult when women have similar names or similar initials, because we often refer to women by their initials to improve confidentiality. We don't like to write all the information on the board all the time. And for some of us, it's difficult because we can imagine things a bit more visually, and therefore we tend to think about the room the woman is in. So we might remember everything about the story, everything about the woman, and say, this is the woman in room 34. And that can sometimes lead to dehumanising and people talking about women as diagnoses or problems rather than women themselves. But sometimes it's just a case of trying to jog your memory. If you remember that you're going to meet multiple people every day, so I might interact with perhaps 20 different women on a labour ward day, then actually me remembering that's that woman in that room and that's what she looks like might be the way I can cope with all that different information, even if I can't remember her name. After we've discussed all the women on the labour ward, we then discuss the antenatal complicated women, postnatal women that are complicated, and any women that are due to come in. So that might be women that are coming in for induction of labour or women that are coming in for planned caesarean section. And it also might include women that are currently having an induction and might need to come over to the labour ward during the course of the shift. Once we've done that, we also then discuss the staffing. So how many midwives have we got? How many nurses? How many theatre staff? How many anaesthetists? And ODPs, the practitioners that support the anaesthetists. And then we'll also have a discussion about beds, how many postnatal beds, how many antenatal beds, how many labour rooms, as well as neonatal cots, so that we're aware of all the potential workload and all the potential capacity we have during the day. Once we've done the handover, we go in and do a ward round. And I know a ward round can be a bit of a controversial thing. Do you go in and interrupt a woman who's in labour? Do you break that bubble of birth and go in and see her and stand round her? And I find that quite a difficult question. So I don't want to interrupt women unnecessarily. And now I can see the baby's heartbeat on a screen outside, and I can talk to the midwife outside the room about the woman she's caring for. But for me, I do like to meet the woman, and I might adjust when I'm going to see her. So if the ward round isn't at a sensible time and she's going to need a review later on, I might postpone it and go and see her then, so she's only interrupted once. But I like to meet the women, and that helps me fix them in my mind, helps me attach the story I've heard to them, and also to see what clinically I feel. So I might palpate, I might feel the size of the baby and where the head is in relation to the pelvis. How is she coping? What pain relief is she using? What support has she got with her? And how does she feel about things? So I really do like to go round and meet the women if I possibly can. And I try and do that in a sensitive way. I try and get the midwife to ask the woman if that's okay and warn the woman we're coming in. And I try and hold the woman's name in my head. So I'll often ask the midwife just before I go into the room, what's her name? And then I'll go in and say, hello, whatever her name is. Hello, Lucy, for example. My name's Florence. I'm the consultant on today. So that I can fix in my mind who she is and what the issues are, so that I can see her as a person rather than just a story that I've had at handover. The other thing about ward rounds that can sometimes be a little bit misconstrued by women is that we'll probably huddle either in the corner or outside the room and have a conversation about her. And that doesn't mean we're saying bad things about her behind her back. That means we're trying to interrupt her less, and the midwife is giving us an individual handover. So by the time I go in and see the woman, I will have had a handover about a woman at the main labour ward board, and then I will have had a little recap in detail from the midwife that is caring one-for-one with that woman. So I've heard that story twice, and that means there's more chance that I've got the story accurately and I've got the story from the midwife actually caring for the woman. And then I'll go in and meet the woman and have her fixed in my head by meeting her and talking to her. And I can check back some of the details of her story with her to make sure that I've definitely understood it all. So those little huddles talking about the woman are my way of not interrupting. We do it outside the door of the room, and then we go in and I can have a conversation with her. So from my perspective, ward rounds are very helpful, very beneficial, but I can see why as a labouring woman that may not be great if a whole load of people come in and kind of tower over you. So that tells you a bit about general shift change handover. Of course, there are individual handovers, person to person, between wards, or midwife to midwife, or midwife to doctor. And those are really important. And it's really important that when a woman moves from one area to another area, she's not having to repeat all the information, and that we have given an accurate handover to one another. It's also important when perhaps a midwife is asking a doctor to come and see someone. Again, we use that SBAR structure. So it might be, situation is, this woman is feeling unwell. The background is she had her baby this afternoon. It was straightforward, spontaneous vaginal delivery. And my assessment is she's now in a lot of pain, and I'm worried she could have a hematoma, a blood clot. My recommendation is that you need to come and see her as soon as possible, and she needs some pain relief. So something like that will give that doctor an idea of urgency, whether or not they need to come and see that woman immediately and exactly what the situation is. The other point at which handover is critical is when we're handing over to other specialties. And sometimes this comes up with really daft hierarchical requests and barriers. And I've been thinking about this a little bit this week because I've been seeing tips for new docs on Twitter. So at this time of year, beginning of August, lots of new junior doctors start, some of whom have just been medical students and are starting their first ever job, and some of whom are starting a specialty. So there's a lot of chat on Twitter about tips for new docs. And there have been some conversations about the stupidity of when you ring and ask another specialty for a review or for an investigation, the fact that you're then told you can't have that because you're not the consultant. They'll only take a request from a consultant. And I see that. Sometimes that happens because it's used as a gateway to prevent excessive referrals. So they don't want lots of doctors ringing up and asking, for example, for a CT scan without having had a conversation with their seniors. And that's partly because a CT scan costs money, and it's partly because a CT scan irradiates the patient. So there's a risk to the patient. But this can be really annoying. It might be I've asked a junior to ring because I've delegated that responsibility. They're free to do that, whereas I am operating or doing something else. So I've delegated to them, only for them to come back and say, I'm really sorry, I rang so-and-so and asked them for a CT scan, and they've said they won't do it unless the consultant rings them. It's a waste of time. It's a complete waste of my time. It's a complete waste of that junior doctor's time, and it's a waste of time of the person who's making that demand, because all that happens is I then ring up and make the same request myself. It's just posturing, and I find it really annoying. Sometimes I've asked the junior to do it because it's good training for them. It's good practice for them to think through, why are they asking for something, perhaps a medical review. And when I say medical, I mean physicians. So if we have a woman who has perhaps a problem that we're unfamiliar with, that we think some medical expertise might be useful for, like chest pain, and we're not certain if it's a cardiac cause, we will refer to another specialty. And sometimes it's good practice for that junior doctor to ring and make the referral and think, why are they making the referral, and to answer the questions that the other doctor poses and make this handover. And I've sometimes sat next to a junior while they do this, only to have the person on the other end say, I'm only going to take the referral if this comes from your consultant or your registrar. And then because I'm sitting next to them, I've literally taken the phone and went, hello, I am Florence, the obstetric consultant. And that's really shocked the person on the other end. And they're like, oh, okay, yes, of course we'll come and see the patient. So it can be a bit stupid. I've also experienced when other specialties come to the ward, perhaps with quite a big entourage. So I don't know why general surgery seem to always have lots of people. And I might be in scrubs, getting on with stuff. We're very hands-on in my specialty. And the nurse in our high dependency or midwife might give a handover. And then I say, what did you think of the patient? What did you think? Do you think it's, I don't know, appendicitis, say? I'm the obstetric consultant, and I can literally see as they're talking, they're like, first of all, why is this person talking to me? And then when I say I'm the obstetric consultant, I see their face completely change because they've made assumptions about me because I'm in scrubs and I'm busy getting on with stuff, and therefore they assume I'm not senior. I don't know. It's really weird. So Handover sometimes throws up some of these slightly weird problems. And I find it myself when I bleep someone and they answer a bit tired, a bit annoyed. Yes, you know, why am I getting this bleep from an area of the hospital I don't normally go to? And then when I say who I am, their tone completely changes. But it shouldn't really. It should be that when someone's handing over and ringing up about a patient and asking for a review or an investigation, that we're tolerant and we listen. Doesn't matter who they are or why they're asking for it. They're asking with good reason, and it doesn't matter if you're busy. They're asking because they're trying to look after the patient. So that is another point when handover can be a bit odd, when we're handing over to other specialties or asking for other things outside our department. And I think this is something that's got a little bit lost. So we used to do, when I was training, a lot of socialising in doctors' messes. We knew lots of doctors in other areas of the hospital, and we had that really personal connection. And I think that's got a little bit lost, partly with the introduction of very stringent shifts and the European Working Time Directive, but also we can get a bit disconnected and siloed in our own specialty. Some of our GP trainees, it's fantastic. They've worked all over the hospital. They might have worked in A&E, in general medicine, in surgery, urology, paediatrics, and they rotate through. And they often will say, "Oh, I will ring the cardiologist because I know that team. I've worked in that team." And as soon as they pick up the phone and they hear it's that doctor that they know, then the response is completely different because you know and trust that person. So there is some sort of lesson there about people we trust and people we don't, and people that we think might be wasting our time. Whereas actually what we should be thinking is we're all there to try and improve the patient's experience and try and care for that patient in the time where they're unwell. I guess those are some observations about handover. We tend to do it better if we know the people we're talking to. Now, today's zesty bit. One of the key things about handover is we can say everything perfectly. We can use our SBAR structure. We can give all the information completely correctly. But how do we know that the person listening has received that? How do we know that we've got our point across and that the information has been heard? And this has cropped up in my trust in some risk reviews. So we've learned that it's really important at the end of handover to check back what the other person has received. One of my consultant colleagues is particularly good at doing this. I will give a whole handover and then he will say, "So I have heard this, and this woman, and this woman are my priorities, and these are the things I need to be thinking about for them. Have I got it correctly?" And that is really good practice. Check back, what has the other person or the other people received? What is their priority? What have they understood? And that will help you ensure that the message has been successfully passed and heard correctly. And then, as I said in the little last portion, when people are handing over, treat them with respect, trust that they're doing so with the best of intentions. If you don't agree with what they're saying or their request or their recommendation, then explain to them why and make some constructive suggestions. Remember, we're all working to the same end, so for the benefit of the patient. And treat people as you would like to be treated. Treat people with respect. That way they'll learn. They won't make inappropriate referrals to you. But it also won't be that the patient suffers because you're not willing to listen to what that person's trying to say. And finally, as a pregnant woman in our department, understand handover is important. Make sure that staff coming on to look after you have got the correct story, and understand that when we're checking on you in the ward round or talking about you outside your room, it's because we're trying to care for you correctly and trying to make sure we've understood all that information. And when we come in and see you as a new team, don't be frightened to speak up and check that we've got the right story and ask us questions that help you feel confident that we know what's happened to you in the preceding period of time. So I do hope you've enjoyed listening to the theobspod. If you have, do like, subscribe, or leave a review, and join me again to explore more about the life of an NHS obstetrician. I'm finding it really exciting to have people listening and give me feedback about what they've found interesting. So please do recommend the theobspod to other friends, colleagues, or people who you think might find it interesting. I'd love it if you'd share with me what you've enjoyed about listening and if you've done anything differently as a result. I can be found on Twitter at FW Maternity and at theobspod. And please do check the MatExp hashtag MATEXP, and the website matexp.org.uk for more information and ideas on how to improve women's experience of maternity care. Finally, I'd like to reassure you that I take confidentiality very seriously, and although I'm talking about experiences from my working life, I'm taking great pains to make sure that I anonymise the stories and talk in more general terms so that I keep confidentiality of my women I currently care for and have cared for in the past very safe. Many thanks for listening.